Good morning. Thank you so much for joining us. So I have the best job. I get to actually pick the brains of the smartest people. So thing is, think about me as your liaison. So I'm going to ask questions that I think are oftentimes at the front of the mind of many of our patients, particularly those who are just learning about their myeloma. So Dr. Lee, you're saying that it's multiple types of myeloma in the same person. And then we learned too from Dr. Callander that it's not only that, it's also multiple types among different people. So are we at that point in time where we could actually customize our treatment so that we're offering something different for the different signatures? I'm going to pick the ladies first.
Yes.
Dr. Lee is my boss. So.
Well, I think we're edging a little bit closer, and I think now if you talk to most people who are getting recommendations for treatment, I think we do spend a lot of time thinking about those cytogenetics that I talked about and FISH studies and say, okay, as Dr. Lee was talking about, that is often used now to say you need 4 drugs to begin your treatment rather than 3. And that's based on some data that's out there, but like I showed you in my talk, that doesn't fix everything. And so I do think we're going to try to get a better handle on all these assessments done after you've finished treatment or you're in the middle of it to decide, do you need to ramp it up or ramp it down? And there are a couple of interesting trials out there going on, one of which is being done right now, looking at a very common combination, lenalidomide plus daratumumab and dexamethasone. And after 9 months, half the people are going to be asked to include bortezomib or Velcade in that, and half just stay on it. And I think that trial is going to be very helpful because it isn't based on what your MRD is. It's based on a coin flip with the idea that maybe if you just stayed on that treatment longer, like I was showing with maintenance, you get better over time. Maybe that's the key. It's not adding more drugs. It's the length of time you're on. So I'll stop there.
I think I'm old, and I remember when I first started, the only thing that we had to treat myeloma patients is melphalan and prednisone, and that was, and there were wonderful studies that said all the cytogenetics that if you had this, you did badly with those kind of therapies, standard chemotherapy. You had this, you did better. You have these genetic abnormalities. And then, again, because I'm old, I remember when bortezomib first came out, and all of a sudden, none of that mattered. All those many of the genetic abnormalities no longer predicted if you did better or worse. So I think one of the challenges, in addition to sort of understanding that heterogeneity, which I think is going to be incredibly important, and I'll come back to that in the second part, is how do our new therapies, and that's actually both the good and the bad thing about myeloma, is that we are developing so many new therapies. A new one comes out every 8 months now. How did the genetics actually predict how you're going to respond to those new therapies? And then as we're trying to figure those out, those new therapies get moved into the frontline setting. So all of a sudden, people are looking at, can you use CAR T cells instead of that high-dose melphalan transplant place? Can you use CAR T cells to consolidate patients? And do the genetics then matter if you have a different way of killing myeloma cells? So I think we are on an Indy car going 250 miles an hour trying to keep up with everything. The other really cool thing, and Dr. Callander alluded to it, is that our technology is getting better and better and better and better. It used to be that, we had just whatever you could measure in the blood, and then, cytogenetics, and we always said, cytogenetics never works because, cells aren't dividing and our pathologists don't tell us anything. And then we got FISH, and that became more complicated or more sophisticated in next generation sequencing. And the cool thing about next generation sequencing is it told us a lot of things, but it told us about the entire crowd, right? So it's like asking this entire room who likes chocolate and doesn't, and just say, all right, 80% of people like chocolate and the other 20%. It's just a whole bunch. Now we have technology that can look at individual myeloma cells and say, what's that individual myeloma cell look like? And once we can do that, we can actually get at that clonal heterogeneity question. Is 60% of the population because all of the cells, have it, or 60%, or is it that some of the cells have a lot of it and the other cells don't have any of it? So that technology, this single cell sequencing technology, is becoming more and more sophisticated. It may actually allow us now to get at questions like, well, do you have 10 clones, 3 clones, 1 clone? And would that help us manage that thing? So again, we are all on an Indy car that's going really fast, and we're just trying to stay in the car. But I think it's a very exciting time for both research and patients.
I think one comment to just sort of keep in mind with Dr. Lee's wonderful summation here, all of our drugs right now, if we even think about targeted therapy, they're not targeted for cancer cells. They are targeting normal biologic processes of plasma cells. So we aren't at the point yet where we're just only killing the myeloma cell. We still have consequences against the normal cells too. And I think that's very sobering to realize, attempts to make very specific targeted molecules in myeloma so far have not been successful.
And Dr. Callander is preaching to the choir. We love that idea. We actually work on normal plasma cells. Also, my good friend Larry Boyce is down at the university at Emory, has actually done this. He has this paper, review called The Tau of Myeloma. And the Tau of myeloma is that half of myeloma is cancer, and the other half of myeloma is actually just normal plasma cell biology. And he says, and he makes this great point. We've sequenced lots of myelomas. We know lots of myelomas and their mutations and all those other things, and we've sequenced lots of patients. And we've also developed therapy for myeloma, separately, just by, trial and error, give patients this drug, see what happens, kills myeloma. And he says, well, all right, if you take those two pieces of data, the drugs that we have and all the mutations that we've discovered, how many of the drugs that we've discovered empirically target the mutations that we've discovered? The answer is maybe 1, right? The BRAF mutation, right? Everything else, 99% of all our other drugs target normal plasma cell biology. They don't actually target any mutations. That doesn't mean that those mutations aren't important, because we know things like RAS and other areas may be great targets and they're developing, but it just shows you the complexity of myeloma, and we have lots still to discover.
I could not start with a better question. So if you missed any of those, go back and watch a recording. Really, that would have saved me several years of reading on myeloma. So you were saying, Dr. Lee, that there were several clones. So how, and some goes away, some remain and evolve and then cause the relapse. How often would then you be looking at these different clones? It sounds like a snapshot look when patients show up to the clinic is insufficient.
It's tough. I mean, and again, I think the new technology will get us to that, because actually, as alluded to, that every individual has multiple clones in them, and actually those clones can live in different places. So Jens Hillengas, who is at Roswell Park, actually did a really interesting study, and a number of other folks at the University of Arkansas have actually looked by PET, as Dr. Callander, and MRI, as Dr. Callander alluded to, is actually what happens to blobs of myeloma in a patient as they get treated. And this is connected to this concept of clonal tiding, that clones tide back and forth. The tide comes in, the tide goes out, depending on what your therapy was. But what Yen showed, and others have shown it, is that if you treat a patient with a particular regimen, some of their myeloma dots on their MRI, on their PET scan, some of them go away, some of them just sit there, some of them get bigger. This is all within the same patient. And until you can get to that level of detail, you can't see it, right? Because if you're just testing blood, you're testing everybody who's dumping stuff into the blood. So you don't know if some clones are getting bigger, some clones are getting smaller. You just know what the average is happening. So the advancement, I think, in a lot of the sequencing technology, the imaging technology, will get us a much better idea of what's going on within a single person in their clones, in their clonal tiding pools.
So, another thing that makes this more complicated, just to ask everybody out here, how many people know that prior to developing myeloma, they had what's called MGUS? Does anybody know that? Okay, so this is what's really complicated about this whole area, because myeloma ends up being, maybe the best way to think of it, it is a problem with the immune system. And even more so than just saying we want to kill every last myeloma cell, what you really ultimately would like to do is make your immune system sort of back in charge again. And it's been known for a long time that there are many people who will go through a series of treatments with myeloma, end up with a clone, end up with monoclonal protein, and be completely fine. And so there are some people who say, we'd like to do that for people. We don't want to just annihilate everything with chemo. What we'd really like to do is restore sort of the surveillance, the sentries who should be out walking around watching to make sure your immune system is functioning. That's what we'd really like to get to. And one of the ironies is some of our treatments are really very suppressive of the normal immune system, and there are consequences for doing that.
And that's exactly right. And so the opportunities are the immunotherapies, the opportunities are vaccines. But I always tell my patients, the only reason, a major reason that you die of cancer is because the cancer gets bigger. If the cancer doesn't get bigger and just sits there because your immune system can control it, it becomes a chronic disease like high blood pressure, right? We don't cure high blood pressure. People with high blood pressure have high blood pressure, but we can give them medications that they can take every day, no side effects. They can live a completely normal life because their disease is under control. So the activating the immune system may allow us, and I suspect that that's what some of the IMiDs are doing, actually may allow the immune system then to keep whatever myeloma you have under control, and it just doesn't grow. And when it does that, you can just go on, live your normal life, and not have to worry about myeloma taking it.
I mean, Dr. Lee gave us great hope that we are going to be hopefully changing myeloma from something that our patients need to worry about all the time to be chronic illness. But let me give a question to Dr. Callander in that several patients are now looking at all of this new data and go, ooh, but they were diagnosed quite some time ago. They really didn't know their genetic information. And could we go back in time? Or is it important to go back in time?
Well, I think it's more, there have been attempts, and I was involved in one of these, to sort of see if you can identify long-term survivors of myeloma. Some of it ends up being circular logic. Well, you did well because you did well, and it's hard. So far in those attempts, and a number of other people have tried to do that, have been able to try to say what really singled out a person to do better. Now, one thing that we haven't mentioned at all, because this is sort of, again, the complexity of myeloma, what did stand out in a couple of different analyses is that a percentage of people did not have bone disease at the time that their myeloma was diagnosed. And that, now, of course, that's all relative because we're talking about people who at least just used to have plain x-rays, and so we don't know. But not appearing to have bone disease at diagnosis has been associated with sort of a better outcome. And that brings up into play, which we're not talking about here, there's all sorts of accomplices with myeloma. It's not just the myeloma cells themselves. They have their buddies. And, the buddies may be the ones who are almost like you're going to go bad, where I'm going to make you, hey, buddy, come over here. You're just kind of walking down the road and you've got this guy who's like, I'm going to turn you into the high life here. So, we think that happens. We really do, that there are these, that other people involved, but I think we just don't understand them. So that's a long-winded way of saying, I think for a person who might have had myeloma for 15 years, and of course, one of the wonderful things is we see those people all the time now. But I don't know that we could analyze, and we've thought about it, I don't know if you've done it, but we thought about going in and say, well, if we took a sample of bone marrow right now, could we understand how they got there? I'm not sure we could.
So goes to say that we're all really quite different, but I really like Dr. Callander's point in that we're talking a lot about the myeloma cells, but they of course don't live alone, and the behavior of those cancer cells in changing other cells around them, right, to really sort of create a home that support them rather than supporting normal cells become a problem, because you can't just target the cancer cells, then you need to figure out how they might talk to other cells around them. And Dr. Lee was mentioning that, it's also where these cancer cells live. They're not always all the same. If they're in some focal area, they may actually change that area a little differently comparing to if they were in the general other locations, for example. So could we move to maybe looking at not doing a bone marrow biopsy or scan and stick needles into those lesions all the time? Or are we going to be able to look at the whole person a little bit differently and maybe even using less invasive stuff?
Greg is waving at me. So I think that I think there's opportunities certainly there. So, for example, a lot of people have been beginning to explore what is known as circulating tumor DNA. So the DNA that you can actually pick up as our technology gets better in the blood. And then the question is, can you sort out, because again, things that get into the blood are an average of everything that's going on in your body. But the power of genomics and genetics, as Dr. Callander pointed out, is you can actually start to pick out subsets. Even the fact that it's a pool of, an average, you can start to pick out subsets, different mutations, and begin to calculate things like how many clones are there, those kind of aspects. So I think that's, again, all very exciting. And I always tell our myeloma patients, the longer you live, the longer you'll live, because the research is so rapidly moving forward that, just hang in there, and answers are coming.